Hello everyone, good evening and welcome. Thank you so much for joining us for this exciting webinar brought to you by the British Lymphology Society. It's lovely to see so many of you joining us so early. We're going to be waiting a few moments for you to join, and please do pop in the chat where you're joining us from, as we know we've got some international registrants. We're delighted to be joined by Cheryl Brunelle. Hi Cheryl. Cheryl's joining us live from Boston, and Cheryl is the Associate Director of the Breast Cancer Related Lymphedema Research Program and Clinical Specialist in Physical Therapy at Massachusetts General Hospital. Breast cancer-related lymphedema is thought to affect 20% of women after breast cancer treatment, and with over 300,000 people diagnosed with breast cancer every year, it's certainly not going away anytime soon. Cheryl has a wealth of knowledge in managing breast cancer-related lymphedema, including shoulder morbidity and deconditioning, and tonight she's going to talk to us about risk reduction and surveillance. We'll be having a live Q&A after the presentation, so please do pop your questions in the questions section. You'll find the little icon down bottom right next to the chat icon. So pop your questions in there and we'll be able to ask Cheryl after the presentation. But now on to the presentation.
Good evening. I would like to thank the British Lymphology Society for the opportunity to be here tonight, sharing some of the work that we've been doing at Massachusetts General Hospital on prospective surveillance and risk reduction for lymphedema and cording during and after breast cancer treatment. And I'd like to thank each of you for joining this evening, and I look forward to a didactic discussion and question and answer period after the presentation. These are my disclosures. So during and after breast cancer treatment, many women experience a myriad of symptoms and side effects, both from their breast cancer and its treatment. If there are areas that we can help mitigate risk or prevent altogether, we should certainly seize that opportunity. And cording and lymphedema are two of those areas. We simply do not want to be seeing limbs so swollen, like the one in the picture on the right, with women coming in with extreme symptoms, impact on quality of life and function. A lot of my team's work as the Associate Director of the Lymphoedema Research Program at MGH has been on lymphedema of the upper extremity and our screening program. So let me share a little bit about our screening program with you. We have had this program in place since 2005, and we have screened over 8,000 women to date. We start screening at the preoperative visit, and we'll talk a little bit more about why that's important in a few minutes. We take an arm volume measurement at that time. We then see patients at their postoperative visit and at every oncology follow-up visit after that time. And this is about every 3 to 6 months. At the post-op visit, we know what surgery the patient has had completed, especially to the axilla. We know what their risk factors are for lymphedema, so we can really start to educate at that point. During the follow-up visits, we take arm volume measurements. We use patient-reported outcome measures to check for symptoms patients may be having that we know might be associated with lymphedema. We perform clinical exams as needed, and we educate our patients a lot about lymphedema and what to look for in between screening visits. We very purposefully start our screening preoperatively. This is the hardest part of a screening program, but it is necessary. We studied 1,028 women in our screening program, and what we found is that 28.3% of women had at least a 5% volume difference in their arms prior to surgery, and 3% had an arm volume asymmetry of 10% or more before surgery. So if we as CLTs or PTs or OTs or physicians are diagnosing lymphedema based on arm volume difference, we may be misdiagnosing a number of women with lymphedema. Realizing that this preoperative measurement is the hardest part of a screening program, We wanted to see if we could take an immediate postoperative measurement or a delayed postoperative measurement at 3 months and use those as pseudo baselines to diagnose lymphedema, knowing how hard the preoperative baseline is to obtain. What we found is that not integrating the baseline measurement results in significant misdiagnosis of 40 to 60%, and that early postoperative measures do not result in accurate lymphedema diagnosis. So we do insist on a pre-op measurement for everyone in our screening program. We measure with a pyrometer or optoelectronic limb volumeter. The patient sits at the table and the hand is rested on the frame, and that metal square frame runs up and down the patient's arm, and the machine calculates volume of her upper extremity. We take the volume of the affected and unaffected arms, or A and U here in this formula, and we enter it into this formula and times it by 100 so that we can come up with a relative volume change percentage. We published this equation as the most accurate mathematical model of limb volume change over time after breast cancer diagnosis. So this is how we speak to patients in the screening program. We will say your RVC is 5%, your RVC is 9%. They know what that means. They know what our thresholds are to treat or to refer, and they watch those numbers carefully and they want to come for measurements. Spirometry is certainly not the only way one can measure for lymphedema. We can use other tools to measure for limb volume, for instance. So a lot of people will need to continue using the tape measure, or there is a 3D camera option now that also automatically measures limb volume and is very easy to use, or the pyrometer. In any case, the relative volume change equation should be used comparing to preoperative baseline. One can also use bioimpedance spectroscopy, which looks at a different construct of extracellular fluid, but also screens for lymphedema over time. Each of these measures is a little bit different, and we need to keep in mind that because they measure different constructs, we may not be diagnosing the same women with lymphedema using different tools. So it needs to be a part of our pie. The measurement protocols really need to be strong, no matter what tool you're using. Staff training is imperative so that you're taking good measurements. I would argue you could take a bad measurement with any of these tools. So it's very important to learn how to use them properly. A preoperative baseline measurement is imperative and required for each of these for accurate diagnosis. In terms of diagnostic thresholds for lymphedema, we use really what's been developed in the literature. For subclinical lymphedema, we use the threshold of relative volume change 5 to less than 10%. For clinical lymphedema, RVC of 10% or more from preoperative baseline. For bioimpedance spectroscopy, we would use an LDEX increase of 6.5 or more from preoperative baseline. For each of these tools, the cost, the space requirements, the time to complete measurements is different. So you would need to consider what the resources are in your clinic or your facility and pick the tool that best represents your clinic workflow. We know what not to do when measuring for lymphedema. We know that we should not be measuring with absolute measures to diagnose lymphedema. This includes 2 centimeter difference, percent difference without baseline, and 200 milliliter difference. These are not accurate ways to measure for lymphedema, and I would like these not to be used in research or clinical practice. They are just not accurate. And we don't base diagnosis on objective measurements alone. We really take all of the data for the woman in front of us to decide whether or not she may carry a breast cancer-related lymphedema diagnosis. So this is how I think about lymphedema diagnosis. We use patient-reported outcome measures. We specifically look for symptoms such as heaviness, change in arm size, or swelling. If the patient tells us any of those 3 things, we know that those 3 symptoms are associated with developing lymphedema in the literature, based on Jane Armour's work and our work in our screening program. We use objective measures like the pyrometer and relative volume change. We use a clinical exam to really see, can we see pitting edema? Can we see visual changes anywhere, even focally in the arm? And we educate our patients very carefully. At the center of our program is really patient vigilance and self-screening. Patients need to know what to do in between our screening visits. They're only with us every 3 to 6 months. So it's important that they understand what to look for and when to call. And we also want to allay some of their fears and give them some autonomy over their lymphedema risk and their screening program. We do this because we have an opportunity to intervene early. This is a lovely study done by Louise Kohlmeyer and her group in Alert in Australia, in Sydney. And they screened 753 women. And they looked at early screening right at the time of diagnosis versus later screening like a more traditional model. And what they found is that women who were screened starting later received care for their lymphedema much later. They had more clinical lymphedema and higher stage lymphedema, which is exactly what we're trying to prevent in screening. So we know that screening offers us an opportunity for early intervention. It's what we should be doing for patients. This is a very busy slide, but it follows my workflow and my thoughts through the screening program and talks about how I integrate both volume, symptoms, and clinical exam into a decision as to whether or not to refer. So we see patients at the preoperative visit. We then establish their risk factors at the postoperative visit. And we determine whether or not they have a relative volume change of more than 10%. If not, then we see, is the patient reporting those symptoms we talked about? If not, do they have edema on clinical exam? Any one of those things, and we consider a diagnosis and refer to the CLT. On the other arm, we have patient self-screening. We want patients looking for symptoms, calling and coming in for a measurement in the event of symptoms. If they don't have symptoms and their RVC is under 10, we just keep screening. A number of organizations have developed guidelines and recommendations for screening. It's simply what we should be doing. The All Ireland Lymphedema guidelines are very specific in terms of what should be expected from a screening program. And on my side of the pond in the US, the NCCN, the NLN, the American Society of Breast Surgeons, they all have screening guidelines and screening recommendations. And I know that the British Lymphology Society also has a very nice publication on what support should be provided for those at risk of lymphedema and what to look for. It's really what we need to be doing as standard of care for patients at risk. And screening is at the heart of every part of continuum of care for these patients. So whether or not we're just continuing the screening, the patient is having no issues at all, or whether we need to monitor the patient with screening while we're trying to prevent lymphedema, either surgically at time of mastectomy or conservatively with a sleeve after surgery, whether we're doing conservative intervention early or CDT, and whether we're doing surgical lymphatic reconstruction for patients who perhaps were refractory to conservative management. Wherever a patient is in her continuum of care regarding lymphedema, they need to go back into the screening program so that we can watch them carefully, because prophylaxis doesn't decrease risk to zero. Conservative intervention doesn't decrease risk of progression to zero. And surgical reconstruction also doesn't completely mitigate risk and cure lymphedema. So I think of screening as our safety blanket, that we're constantly watching patients and we will notice any changes. In order to screen well, we really need to understand what the risk factors are for lymphedema. In the woman in front of us, what is her individual risk factor? These include node dissection, nodal radiation, not just radiation to the breast, but to the regional lymph nodes, BMI more than 30 at cancer diagnosis, low volume or subclinical early swelling, Black race, Hispanic ethnicity. Breast reconstruction does play a role in lymphedema risk. We'll talk more about that, and cording. A few of these warrant some conversation, so I thought I would go through a couple of them. The first being node dissection and regional nodal radiation. We looked at data from 1,815 women in our screening trial, and what we did was we stratified these women by axillary management. So we had 4 groups: sentinel node biopsy with or without regional nodal radiation, and axillary lymph node dissection with or without regional nodal radiation. And what we found is that women who underwent node dissection were at 3 times the risk of lymphedema as those who underwent node biopsy, so almost 25% risk versus 8% risk. The second finding we had is that whether or not a woman with sentinel node biopsy underwent regional nodal radiation, her risk of lymphedema was not statistically different. And that held true for lymph node dissection as well. So we concluded that although regional nodal radiation adds to lymphedema risk, the main risk factor for lymphedema is really node dissection or axillary surgery. When I'm working with newer CLTs, I like to show them these two pictures to illustrate why I think this is true. The picture on the left denotes sentinel lymph node biopsy, in which dye is injected at the site of the tumor and is taken up by the sentinel or first lymph nodes to take up that dye, and those nodes are removed and tested for cancer. In contrast, in lymph node dissection, the surgeon is removing the contents of the axilla to the medial border of pec minor and taking out the axillary fat pad along with those lymph nodes. That tissue is sent to the pathologist for testing. Lymph nodes are counted and tested. So it is a much more invasive surgical procedure, which probably explains why clinically we see patients post-node dissection having difficulty with movement, having a lot more discomfort than those who undergo sentinel lymph node biopsy. This probably also explains why those with lymph node dissection are at a much higher risk of lymphedema. It is not number of lymph nodes. We've looked at that in our screening program. It is actually the surgical procedure. What about subclinical swelling? We wanted to look at how many women in our screening program developed subclinical lymphedema, and then of those, how many went on to develop or progress to lymphedema. This cohort was taken at a time when we didn't treat subclinical lymphedema at all, and this study had a nice long median follow-up of 30 months. And you can see here the figure on the left denotes the onset of lymphedema amongst those who had lymph node dissection and lymph node biopsy. And what we found is that those who had lymph node dissection in our screening program, about 40% of them developed this subclinical lymphedema. And of that group, 39.2% went on to progress to lymphedema in absence of treatment. So that's rather high. And if I have a woman in front of me in this scenario who's developed low volume swelling after node dissection, I have that conversation with her that you are at a 40% risk of progressing to lymphedema in absence of treatment. Perhaps we should consider treating this. I don't mind why the swelling is going away, but we do want to get rid of that subclinical lymphedema. In contrast, if a woman in front of me is in the same scenario with sentinel node biopsy, I would tell her that about 24% of our patients get this subclinical lymphedema after node biopsy. However, only about 11% of them go on to progress to lymphedema in absence of treatment. So we have some time here to watch you very closely. I usually try to take measurements at 2 and 4 weeks post, do clinical exam, have her back in, watch this very carefully, and almost 9 times out of 10, this reverts back to normal. But I also, again, have the safety of a screening program. So we know that there's higher risk of progression to lymphedema after node dissection than node biopsy in these patients with subclinical lymphedema. So that will guide what I think about early intervention for these patients. Black race and Hispanic ethnicity has really come to the forefront in terms of lymphedema risk in the last few years. And I just highlight 2 papers. These aren't the only ones, but 2 papers. This one, Kwan et al. Found that Black women had a 2-fold increased lymphedema risk compared with white women. And this other paper out of Memorial, a really nice screening program in New York City, found that Black race and Hispanic ethnicity were independent risk factors for lymphedema. So that's really something that we should be looking at. And the odds ratios are quite high. These women are at much higher risk than white women after breast cancer treatment. Finally, the role of breast reconstruction in lymphedema risk. There have been 6 papers now that have found that those who undergo breast reconstruction are at a lower risk of lymphedema, and certainly that breast reconstruction does not increase risk. One of these papers was ours, specifically finding that those who undergo implant-based reconstruction is really the first type of reconstruction that we try to do at MGH, these women had a lower lymphedema rate than those who didn't undergo reconstruction. And I put the references here for your review. There are three hypotheses as to why this happens, because we were a bit confused by this data initially, and it's an important point when we're talking about reconstruction with patients because they're worried about lymphedema. If doing a skin-sparing mastectomy, this preserves lymphatic channels in the skin, while patients without reconstruction undergo more skin resection and therefore more lymphatic vessel resection. The tissue expansion and capsular contracture associated with implants may lead to lymphangiogenesis. And thirdly, without reconstruction, we know this as CLTs, that there's more adhesions and fibrosis and tissue adhesion against the ribs and the chest wall. And this may lead to obstruction of lymphatic flow. But we are not entirely sure why this is the case. Other risk factors for transient lymphedema or lymphedema may include taxane-based chemotherapy, targeted therapies, lymphatic anatomy, or genetic predisposition. And there's some studies undergoing in these areas as well. We screened for 5 years very purposefully. We looked at the timeline of onset of lymphedema and the risk of onset of lymphedema over time, and we stratified by axillary treatment. And what we found in our whole cohort of 2,171 women is that the highest risk of lymphedema onset was between 12 and 30 months. However, when we break this down by axillary treatment, we found that those who had node dissection and are at much higher risk develop lymphedema much earlier and are most likely to have that onset between 6 and 12 months postoperatively. However, when we look at the lower risk group, those who had sentinel node biopsy, we found that their onset was much later. 36 to 48 months was their highest risk of onset. So this is an important point because this low risk population is often not screened, and the onset of lymphedema at that point can be quite subtle and when they're least expecting it. So we educate these patients to understand that this can be the case, that it can come on later and subtly, and we still want them to be calling us and looking for this at 3 to 4 years out and continue screening with us. So we educate patients about their individual risk factors, their anticipated level of risk of lymphedema, what to expect from our screening program, signs and symptoms of lymphedema. Specifically, we're looking for those symptoms including change in arm size, swelling, and heaviness, that the signs can be subtle, and who to call, and that we want them to call. If we notice any changes, we would really like them to call. So how do we translate this to practice? Well, we make sure that we're doing a baseline preoperative measurement. We screen for 3 to 5 years. We individualize education, and we understand that low risk of lymphedema is not no risk, that minimally these patients deserve a baseline measurement, education, vigilance, and self-referral options. But best practice is really longitudinal screening, as we should be doing per many guidelines at this point. We should also be screening for breast edema after breast-conserving treatment. This can have a major impact on women. It can be quite uncomfortable and affect their function and their daily life quite significantly. This is an area that our team is very interested in studying prospectively, and we recently published a review on breast lymphedema in 2023, including 27 studies. And probably the best prospective study we have on lymphedema to date is by Karen Johansson's group. And she used tissue dielectric constant, which measures for subcutaneous fluid, in 65 women, and she screened them for 2 years post-radiation. And what she found is that there was more subcutaneous fluid in the affected breast at every visit up to 2 years post-radiation, that this tissue water increased during the first week of radiation and stayed elevated throughout, and that the highest incidence of breast edema was at 3 to 6 months postoperatively, and the smallest incidence was at 2 years postoperatively at their last follow-up. So it seems as though these women tend to worsen after radiation, which clinically I see this 3 to 6 month period post-radiation So I will educate women that this does for most get better over time, over 2 to 3 years, but that's a very long time. So I do consider treating those who are symptomatic and reporting an impact of breast edema. We consider potential risk factors. These are some potential risk factors in the literature, but we really don't fully understand which women are at risk of breast edema after breast-conserving treatment, and we really need a nice prospective study to look at this. What we see in breast edema is that the affected breast is larger, it's heavier, it can be quite tender, possibly not the whole breast, but in areas. In other women's, globally, the whole radiation field is tender. We can see peau d'orange or enlarged pores. We can see erythema, as you do in this photo, a pale, thickened areola, tissue fibrosis, and pitting edema, especially just above the inframammary fold in the dependent areas of the breast. And these patients report worse body image, higher levels of pain, and lower physical functioning. So it's important that we treat those who need it. If you have access to routine imaging such as mammography or ultrasound, you can see the skin thickness on that. So I'd encourage you to take a look if those tests are in the patient's electronic medical record. And you can see in picture A here on mammography and picture C on breast ultrasound, the increased skin thickness associated with breast edema on these images. So how do we translate this to prospective surveillance or screening practice? We educate patients that this can happen, that the breast edema is common after breast-conserving treatment. We educate them about the timeline and that the symptom presentation varies greatly. This simply doesn't bother some women, whereas others are incredibly bothered by it, and that it may worsen over time after radiation, which is not always the expectation. We ask about symptoms. We look for signs. I have women take their clothing off, bra and shirt off from the waist up. I give them a gown and I offer a full clinical exam looking for cording, looking for breast edema, looking for lymphedema, looking for tightness and muscle imbalance. So that whole upper quarter can be really examined well during my initial examination. And I consider whether symptoms are impacting quality of life or function and treat the patient if she wishes to be treated. I'm quite comprehensive in my treatment, and I try to fill the patient's toolbox with treatments. They quickly figure out what's working and what is not working. I use compression bras and vests, chip bags, swell spots. I make some. There are some that are commercially available. I do a lot of kinesiotaping for edema. I love this book on kinesiotaping for edema. There's some nice options for the chest wall, the trunk, the arm, the lower extremity in terms of edema. I maximize drainage by using an external prosthesis in the bra. I do a lot of myofascial work and manual lymphatic drainage, both in clinic and teaching the patient how to do this with a video as well that she can take home and just follow and copy at home to be doing lymphedema, manual lymphatic drainage. And this is something that I check several times in clinic to make sure they have the right hand positioning, the right directions, the right pressure, and the right strokes. We'll switch gears now to cording or axillary web syndrome. This is an area where we've certainly been looking at and publishing in our research program. And cording is characterized by radiating pain from the axilla down the arm as far as the root of the thumb, limitation in shoulder range of motion, especially into abduction, this linear axillary web of tissue traveling down the anterior side of the arm, sometimes all the way to the root of the thumb. This can be one cord. This can be a web of cords that you can see. You can also find this on the breast or anterior chest. And on the anterior chest, I look just along the nipple line, just below the inframammary fold into the abdomen. And it can be a postoperative phenomenon, although it is not always a postoperative phenomenon. For years, we didn't really understand what the etiology of cording was. Now we understand that it's consistent with lymphatic origin, specifically dilated and thrombosed or occluded lymphatic vessels. So that helps me understand how I'm thinking about treating these patients. But it also made me wonder, does cording increase lymphedema risk? And I draw your attention to this picture here, which is a nice picture of one of my patients whose breast cording came from her node dissection scar directly and almost all the way around the breast to the median of her chest. So I wondered, does courting increase lymphedema risk? So we looked at this with one of our studies, and we aimed to identify risk factors for courting and whether or not courting was a risk factor for lymphedema. So we analyzed data from 1,181 patients in our screening program. Courting was self-reported, and lymphedema was defined as RBC more than 10% from baseline. What we found is that cumulative incidence was high, and over 31% of the cohort developed courting at some point. We had a nice long follow-up of 24.3 months postoperatively. And you can see in the first 12 months here, the courting incidence just went up so steeply. And again, from 12 to 36 months, the courting incidence was continuing to rise, and then it really plateaued. But interestingly, what we found is that those reporting courting were more likely to have lymphedema, to have lower body mass index, and to be younger. And this is really clinically what I see. Active, younger, thinner patients develop courting. They're also more likely to have had mastectomy, node dissection, regional nodal radiation, and chemotherapy than those who did not report courting. Historically, we've always thought of courting as a postoperative phenomenon, but in this study, we found that the median time of first courting report was actually 4.5 months postoperatively, and many reported courting for the first time later. And the median time of last courting report was 13.2 months postoperatively, with many having courting much later. So this is a phenomenon that can come on beyond the post-op period. It can linger for a very long time, and in fact, it can recur. Most interestingly, of those who developed lymphedema and who also reported courting, 86% reported courting before the onset of lymphedema. So to me, there has to be a connection here. Functionally, this was a bit of a surprising finding, but functionally, those reporting courting were more likely to report difficulty with all 17 functional activities that we asked about, including things like typing on a keyboard for 20 minutes. So functionally, these patients can be quite limited. Those who reported courting had 2.4 times the risk of upper extremity lymphedema than those who did not report courting in this study. So we also saw that the symptoms reported most frequently by those with courting were tenderness, aching, and firmness or tightness. And clinically, this makes sense with what I see in the clinic. These conclusions in this study was contradictory to one or two other studies, and we did receive a letter to editor in this area. And what we wanted to do was take a step back and take a look at the literature and write a systematic review in this area. So the aim of this review was to identify if axillary Webb syndrome was a risk factor for upper extremity lymphedema. We found 9 studies for inclusion. There are not a lot of studies in this area. These studies are from all over the world, all different study designs with very different median follow-ups from 2 weeks post-breast cancer surgery to 5 years and to 10 years in one study. Populations were quite different in these studies, and risk factors, unfortunately, that we know to be the case for lymphedema, such as nodal radiation, were not reported in most studies. The diagnostic criteria for courting was very different across studies. And what this resulted in was a very different incidence of courting across the studies, everywhere from 28.8% to 57.1%. The same could be said for lymphedema. The diagnostic criteria across studies was very different, with only 3 studies incorporating preoperative baseline, which we know is important, also resulting in different incidence across studies from 9% all the way up to 52.5%. Only 3 of those studies, one of them being ours, found that axillary Webb syndrome was associated with increased lymphedema risk. We also have to look at the quality of these studies. And we measured this using the modified Downs and Black score. And what we found that all of these 9 studies scored either poor or fair on this scoring. Keeping in mind that an excellent score on modified Downs and Black is a large randomized blind controlled trial, which is very seldom seen in this area. And some of these studies were very good studies, but all were poor or fair in quality. When we did a pooled meta-analysis, we did find that axillary Webb syndrome was a risk factor for lymphedema. However, when we look at study heterogeneity, there was an I-squared of 82%, which is extremely high and probably explained by the methodology differences and population differences across studies. But that is really an unacceptable amount of heterogeneity when comparing studies. And we also graded them using the Cochrane grade scoring criteria to look at certainty in this body of evidence. How confident are we in this conclusion? And they scored very low. So we concluded that the available evidence base doesn't definitively determine whether cording imparts a risk of lymphedema. However, I would point back to the strongest study that scored, that we included, that found that axillary Webb syndrome more than doubles lymphedema risk in the upper extremity. So we feel that cording should be considered a potential risk factor for lymphedema until definitive conclusions from methodologically sound prospective studies are available. So how do we translate this to screening practice? We educate patients about cording, that it's very common after breast cancer treatment. It's of lymphatic origin. We help them understand what it is. It can be very disconcerting to suddenly see a cord down one's arm when one doesn't know what cording is. We educate about what we think the risk factors are based on our study, the most likely symptoms that they might feel and when to call us, and that it can occur in the axilla, down the arm, in the breast, in the abdomen, and it's very possibly an additional risk factor for lymphedema. So we consider lymphedema treatment techniques. Because I know the etiology is lymphatic in origin, I want to get that lymph vessel flowing again, and I do consider how I'm treating this. We really don't understand well how to treat it well from the literature. So I tend to, like breast edema, throw everything at this, fill the patient's toolbox, and she very quickly discovers what is working and what is not working. So I do use warmth over the area of cording. These women love to stretch in the shower. I want them to move and stretch. Cording very much prefers when women don't move and stretch, and it can tighten up. I use a lot of manual techniques like scar mobilization and stretching, skin stretching, manual lymphatic drainage. I teach that to the patients. I kinesiotape in drainage patterns, and I consider compression. If a patient has some inflammation in the area and is quite sore, I consider putting a day sleeve on, and in some cases really helps with symptoms. However, we need studies in this area to understand how to best treat cording. So in conclusion, in regard to cording, breast edema, and lymphedema, the take-home messages are really that screening must start at breast cancer diagnosis, not postoperatively. We want to be seeing women at the point at which this woman's swelling is on the picture on the left in the green photo. That's how most of my patients look when I start to see them. The women in the pictures on the right are so late-stage lymphedema. They have late-stage lymphedema, symptoms, major impact on quality of life. This will require a lot of treatment and could, in fact, be quite refractory to treatment if this tissue has transformed to a more fat-dominant swelling. So we start at breast cancer diagnosis. We understand the patient's risk. We inform the patients what signs and symptoms they might encounter. We empower them with this information to give them some autonomy over their screening program. We tell them when we want them to call us, who to call. I make sure that I'm looking at the whole upper quarter when I'm doing an initial exam. Often I find things that the patient didn't even know they were there, and we can treat them and we can watch them carefully. And we fill the patient's toolbox with options for treatment as well. I'd like to acknowledge my team. This is our team since 2005. It really does take a village, and I'm very lucky to have one. And I'd like to thank you for your time. This is the contact information for both our website, which includes all of our research, our email, and our Twitter feed. I look forward to a discussion with you now. Rebecca, I can't hear you. I don't know if you can hear me.
Wow, Cheryl, thank you.
There you
Can
are.
you now?
Yes.
Wow, thank you. What a fantastic presentation. Thank you so, so much for a whistle-stop tour, which I know is only a very small part of your research and your day-to-day work. But thank you for helping us to understand what it's like for you. And we've got lots of questions coming in. So without further ado, let's get over some of those. But first of all, I just want to ask you about, you have such a unique screening process at Massachusetts General. And really, I want to know, how has this changed your practice? How has it changed the outcome of your patients?
Thank you. Thanks again for having me. I think the main way that the screening program has really changed, it's completely changed my practice as a CLT, because I see patients early. There are very few patients who have a 20% edema or 30% edema. It's just not what we see. We see them so early that their symptoms are, for the most part, not moderate or severe, which is great. And we can treat that early stage lymphedema, which is much more likely to be treated successfully. Whereas when we see those later stage lymphedemas, they're much more refractory to treatment. And many more of those women go on to end up needing lymphatic surgery or such, versus what we can do early. So, and I have the benefit of that screening program as a safety blanket. So when I finish seeing them early, I want to screen them very carefully for the next year or more, at least monthly, so that I can make sure that what we're doing is working and they are not progressing at all. And if they are, then we catch it again very quickly and have them come back in right away.
Just wow. If only that was my experience in the NHS. Thank you so much for that. And a question that Justine has submitted, which was the same question that I also had, was when you talked about the reconstructive patients having a reduced risk of developing lymphedema. Is that with immediate reconstruction or delayed reconstruction?
So actually just went back while that question came up to all the papers, and in all the papers, it's immediate. I know our findings were immediate implant reconstruction. It also included immediate tissue expander reconstruction and immediate autologous reconstruction. I think it's an important distinction to make, though. I know that Dr. Mavrara at Memorial would say this. It's not so much about lessening risk. So it's more so not about increasing risk of lymphedema, because it's quite a big surgery, the reconstruction, but that does not increase risk of lymphedema. We don't use lymphedema risk after reconstruction in our discussion about which types of reconstruction or whether or not a patient will choose to have reconstruction preoperatively.
Okay, I think that massively helps us with sharing information with patients who are perhaps fearful about undertaking further surgery because of developing breast cancer-related lymphedema. There's a question from Rebecca who's asking, is it known why Black race or Hispanic ethnicity patients are more at risk of developing breast cancer-related lymphedema?
That's a really good question, and we really need to do more research to understand the biologic mechanisms of this. Unfortunately, we do not have a very diverse population at Mass General in Boston, so we may be part of some of these studies, but I think this is going to take a very large cohort, multi-site study to really try to tease out why these women are at higher risk. And these studies were done very well, so they controlled for the risk factors for lymphedema. So it's not just because a certain race may have a different body makeup or body mass index. And we really think there might be a true biologic mechanism or genetic mechanism associated, but we need to find it.
Yeah, that's the kitty. That's the difficult one, is pulling that out and finding that. And while we're on risk reduction and early diagnosis and intervention, Lorraine has asked, do you find that your patients still need lifelong treatment for their lymphedema if they've been picked up so early?
Yes and no. I think they need lifelong screening, because our early intervention does not completely mitigate the chance that they could develop swelling more later as well. However, I'm approaching women at high risk who develop early stage or subclinical lymphedema, so 5 to 10%, and trying to do 6 months of compression with them. Again, there's no good study to tell us what to do for these women, but I'm trying to do 6 months of compression therapy with them consistently every day, 12 hours a day, seeing how their arm is responding, seeing how symptoms and clinical exam are responding, and then trying to wean that compression if I can. I would never do that without my screening program because I would feel very nervous about that. And many women do quite well. I find that if the arm is going to reaccumulate, it does so quickly. So we'll catch that kind of creep up 2, 3, 4% within a few weeks. And I know that her arm has declared itself as needing some compression. So we really just kind of go with what the patient needs, and things change so quickly with compression and surgery for that matter. There's so many options available to these women. I think the most important thing is finding something feasible to fit into her life, and what fits into one woman's life compression wise is not what fits into someone else's. So it's very individualized. We spend a lot of time on custom compression options and just trying to maximize quality of life in the event that a glove and a sleeve need to be worn during the day. It's very hard.
Yeah, and depending on your occupation, your lifestyle, like you said, it has to be so personal and that person-centered care.
Right.
Kate asked about validated measuring guidelines for breast cancer related lymphedema of the breast, back, and chest. Are you aware of any guidelines?
Such a good question. Breast edema is something that we're working a lot on right now, our team, and trying to put together a large prospective trial, a collaborative trial on this. There aren't any validated measuring guidelines that are routinely used in clinic. Probably the main two cutoffs or tools that are used is the tissue dielectric constant, the inter-breast ratio of 1.28 from Karen Johansson's work, and a couple of other papers after that, using the tissue dielectric constant, and the ultrasound skin thickness as well. There are some studies about that as well, but there's nothing that's really universally available. And most clinics don't have a TDC or an ultrasound handy in the ambulatory setting. I think that might change if we can develop cutoffs, because there are some very tiny ultrasounds now that you can have an app on your phone and a handheld ultrasound and do skin thickness, and the tissue dielectric constant is tiny as well. So I think maybe more to come, but right now, not really.
Thank you.
And sorry, Becky, and back and chest. So back and chest wall, there really isn't anything yet.
No, I hope that is going to change, as you say, so we've got something a little more objective in clinical practice, never mind from a research perspective.
Right.
Now, some questions about cording. And Carol asks, have you looked at the effect of scar therapy on cording and lymphedema, or reflexology for lymphatic drainage, as both have proven results for improving movement and limb volume?
So scar therapy, I think I incorporate that into every patient with cording, because typically the cords come straight from that axillary scar or from the breast scar into the abdomen. So I do incorporate that routinely, not as a standalone treatment. I tend to throw everything at cording and kind of fill the patient's toolbox, and the patient quickly figures out what helps and what does not. I did scar therapy this week with a patient, and it was not working for her. We ended up focusing more on MLD techniques and taping, and she feels much better. So again, it's very individualized. I am aware of one study on reflexology, I believe, and lymphatic drainage. It's a really small study, though. I don't think that there are any large studies in this area. I could be wrong, but I'm not aware of them. I think it's important to look at some of these integrative therapies and integrate them, no pun intended, into treatment as well, because patients are looking for options that are not yet another medication, for things that are inflammatory, like scars, and for either lymphedema or cording. So right now, we don't have great studies that are really picking out components of treatment. It's like CDT, right? We can't pick out components of treatment yet and point to these large randomized trials. We just don't have them.
No, and Megan was alluding to that with her question, saying, have you any idea on how an excellent quality study could be carried out in the area? How would it look? Double-blinded, randomized controlled trial, or is it even possible? And also congratulated you on an excellent presentation. But I think you've kind of answered that question, that really at this moment in time, it's just not possible.
I think we try to collaborate whenever we can with other groups, like with the breast edema. We're collaborating with Louise Kohlmeier's group in ALERT, which again has a lot of patients. So if we can bring groups like that together who are measuring in the same way and do multi-site large trials with a variety of patient types across the globe, I think that's what we need. I don't think any one clinic is going to be able to do these trials. We're a large clinic and we just don't have the numbers, and we don't have the diversity that's needed to generalize. So it's going to take coming together, and it's going to take funding. We need funding to do these big trials. Are extremely expensive. Yeah. And it is very hard to secure funding for some of these trials. We try. A lot of our time is spent on funding, as you know.
Yeah. Application after application.
Application after application. So I think it's easy to put together a protocol for a study. It's much harder to make it happen and make it generalizable. But we'll get there eventually, I think.
We need that positivity. Thank you. And Rebecca asks, have you seen cording go down to the ulnar side of the wrist, down to the little finger, as opposed to going to the base of the thumb? Is that something you've come across?
Yeah, I saw that question pop up. It's a really interesting question, Rebecca. I have not. I've never seen it. I've definitely seen it, medial elbow, like on the ulnar side of the upper forearm, but not towards the little finger side of the wrist. I'm sure maybe somebody has seen it. Everyone's lymphatic anatomy is different, so I have no doubt it's probably been seen. I've just not seen it.
I think it's really interesting that it's probably not widely accepted in more generalists who are not lymphedema specialists that cording is a lymphatic problem and is, a lymphatic originator and originates from the lymphatic system. I don't think that's still widely accepted in the sort of general breast surgery sphere and in some plastic surgery spheres as well. And it's really great to have that as a take-home message to share with colleagues today from your presentation. And Emma has asked, can cording ever completely resolve, or does it always have to be managed? You did talk about recurrence.
First, Megan just added that she's seen the ulnar side cording spiraling around the wrist. So I'm not surprised that someone's seen it. That's absolutely not surprising. And can cording ever completely resolve? Yes. I have seen cording completely resolve and the patient's never been bothered with it again. What we found in our cording paper, looking at that over time, is that for some it recurs, which is interesting. You think it's gone away, and then in fact it recurs. The patient thinks it's gone away too, and it's recurred, or it lingers for some. I'm really curious to figure out why in some women the cording just sticks and lingers for months or years, and then might eventually go away. But for many, although you can see the cords, we can manage the symptoms. Okay. And to me, that's the most important thing. And to most patients, that's the most important thing, because cording's uncomfortable.
If you're the one suffering, yeah.
Right. And some women do not like the look of cording either, down the arm, of course. But for most, improving the symptoms is the main goal. And hopefully after that, inflammation goes down, the visual cords start to recede as well.
Okay. And while we're on cording, a question's come in from Johnny about Mordor's syndrome, and that being related to lymphatic cording. My lady was told about this, but not completely convinced. I think that means Johnny wasn't completely convinced, not the patient.
Yes, right. And Johnny's corrected. It's Mondor's syndrome. Yes. These terms have been used interchangeably in the breast. Is it cording? Is it Mondor's syndrome? It's literally been used interchangeably. I don't think we really fully understand it. They both tend to look the same in the breast, from my understanding as well. So they have just been used interchangeably. I don't think we have a great understanding of that.
So the treatment would be the same.
Mm-hmm.
You wouldn't need to differentiate.
I do not.
Okay. And I think thinking about the self-report that you talked about earlier, that's probably where this comes in. So you talked about that personalized care and individualization, but also about the patient-reported outcome measures. When do they fill those in from a surveillance perspective?
So they fill them in at each screening visit. We have an iPad that our research coordinators will just bring to the patient while they're in the waiting room, or when they come to the barometer area, they can fill it in there. And if they don't get it filled in there, we can send them a link to their phone and they can fill it in that later that day.
Okay.
It's a busy day for many of them when they're in. We try to get the symptoms filled out when they're at the clinic so we can take a look at spirometry and symptoms same day and kind of put that data together. And if any of those symptoms show up or there's early swelling, then generally a referral is made and then we get to see them.
Okay. And so that's an ongoing thing for them that continues throughout that whole process. So that they're reporting different things with each time you see them, presumably. And then thinking about their lifestyle choices, what information or advice do you give them regarding their lifestyle choices?
That's a whole webinar in and of itself, I think. Our group has done a lot of work on what has historically been told to patients about precautionary measures, having injections, having blood pressure measurements, flights, trauma, infection, all of that. I think we've definitely written the largest studies in that area. Although, again, you will never have a randomized controlled trial in this area. We can't randomize women to receive an injection in their at-risk arm, for instance. So if patients have unilateral breast cancer surgery with unilateral lymph node removal, many women still prefer to get medical procedures done on their opposite arm, on the arm opposite to breast cancer. And I think that's fine. It's a personal choice. And they have that option. Unfortunately, we started to do this work because many women either have lymph nodes removed bilaterally or they lose venous access on one side during their chemotherapy regimens. And during that last 1 or 2 chemotherapy cycles, they might need another option. So for those women who don't have other choices, we've looked at that and have found it not to be a problem. Blood pressures, flights, duration of flight, number of flights, and venipuncture. We have not found it to be a problem. In fact, we haven't found infusion of chemotherapy to be a problem either. We just haven't quite published that paper yet. So we don't throw caution to the wind and tell patients do whatever you like. If you need to use that arm for isolated procedures, 1 or 2 injections, 1 or 2 infusions, it looks like that's safe from an arm volume standpoint. So I will get calls from patients who are very upset that, they were talking to the doctor and there was a blood pressure taken on the at-risk arm without them realizing or just facing the other way. And it's fear-inducing. Yeah. So it's been very nice to use that data to be able to say, it doesn't appear that you should have a problem. It's an isolated measurement. You should be fine. We also have the screening program. Come in, get screened a few extra times. We try to allay their fears with that. So again, we're not saying throw caution to the wind and do everything on the at-risk side. But if you need to, it appears as though isolated procedures are safe.
Thank you.
We want women to live their lives, and we know that a lot of the things we used to tell them about don't exercise, don't use weights, Katie Schmitz's trials, proved that wrong. And now we tell patients lift weights in a supervised progressive way, exercise in a supervised progressive way, and get back to all the things you love doing. We want them to live their lives. So we are very liberal about the exercises that we're doing. We have patients powerlifting and marathon running and all the things they want to get back to doing. Many of the things we've told patients historically are just not based on evidence.
No. And we know that there's an increased survivorship with exercise. If we could prescribe it, we definitely would. So it really fits in well with that. Why do you believe that some women are much more symptomatic than others with breast edema or breast cancer-related lymphedema of the upper limb?
We don't understand that either. And we do know from a few studies, though, that the relationship between the amount of swelling and the severity of symptoms is non-existent. That I have patients with very little swelling who are very symptomatic and bothered. I have a woman who has so much swelling, she's had lymphedema for years and years and years, and it doesn't bother her. I can't figure it out. I'm really glad that someone with severe lymphedema is not symptomatic with it. She actually just lives her life, and she's had this for 20 years. But it bothers me when someone's volume isn't very high, but yet they're very symptomatic. Then I think we just need to be very aggressive with treatment and try to focus on getting those symptoms down if possible.
And final question from Brenda in our discussions there about what about steroid injections into the affected lymphedema side?
That's a can of worms, but it's what I say to patients is what I want. I'm assuming that Brenda's talking about a woman with lymphedema.
I think so.
So we see lots of women with lymphedema who develop rotator cuff tendinopathy and things like that. I do what I can to avoid an injection in that side if possible. Certainly conservative management works for many of these patients, and we can avoid an injection. If in fact the quality of life is so impaired because of the pain, I really want an arm with lymphedema moving. Priority one is to keep it moving. So I will go ahead and do that. I will go ahead, and I won't do the injection, but I will say if that's what you wish to do in conjunction with the orthopedic specialist, and he's recommending that, there's one who I tend to send patients to, and he's lovely. And he will only do it in very particular cases, which is great. But I've also had patients who've fractured their shoulder and had total shoulder replacements with lymphedema. And the surgeon calling saying, I really don't want to do a shoulder replacement for this woman. And I'm saying, well, she has a completely non-functional shoulder. I want her moving. And we've just seen her preoperatively, postoperatively, and followed her through her rehab. And I've actually had 3 of those now, and they've all done very well. And they've ended up with less lymphedema than they started with. I don't know why. They're moving well. They're strong. Maybe because they're strengthening so well and their range is good, and they have this really functional arm. So it's very individualized. Yeah, it's individualized, but it's focusing on, are there other options? And if there aren't, then consider and just watch very carefully and treat judiciously.
We really cannot thank you enough. We've put you on the spot. We've thrown questions at you right, left and centre. Some that are, we've pushed there, like you said, could have been a whole nother webinar. Maybe that's what we'll do and have you back for another one if you'd be willing. You can see from the comments that you've really enlightened so many of our audience. I've learned absolutely loads, and we cannot thank you enough, Cheryl. The video will be available afterwards on the BLS website, and we really encourage you to share the link with colleagues who work in breast cancer management, in oncology, in surgery, and associated fields, because we do feel that this information is little known and still needs spreading far and wide, and will make a difference to the ladies and men that we're encountering with breast cancer. And as we said, those numbers are not reducing. So thank you all very much for joining us. Thank you, Cheryl, and thank you to the British Lymphology Society. Take care. Bye-bye, everyone. Bye-bye.